Good evening, everyone. Ocular emergencies and management is a very vast topic, but fortunately, I have Dr. Parihar sir for my rescue and Dr. Tulika, who has already explained chemical injuries a lot. So I'll be excluding these topics, which actually constitute the real ocular emergencies. Okay. So what is an ocular emergency? So from our perspective as an ophthalmologist, I can define it as a condition which potentially will result in permanent loss of vision if it is not attended to urgently and appropriately. And with the word appropriately, I mean the appropriate referral also, because many a times a patient who is having an eye problem in the middle of night might not come into contact with an ophthalmologist but go to an emergency department of any hospital, and his first contact must be with a non-ophthalmologist person. So it can be divided into trauma-related, physical and chemical injuries, which, as I told you, chemical injuries have been discussed, and the physical trauma will be discussed in detail by sir. So I will be concentrating on the non-trauma related conditions. So most of these conditions are, again I'll emphasize, are not the actual emergency, which we mean by that they are to be treated there and then only, but they need a proper diagnosis at a proper time, and after instituting an appropriate first aid, they have to be referred to an ophthalmologist in time. So these include infections, acute glaucoma, acute anterior uveitis, vascular diseases, and retinal detachment. So the presentation is important. We must be aware of the signs and symptoms of the conditions which require your urgent attention. So while taking the history and while examining the patient, you must note that what the signs and symptoms are. The important ones are the sudden loss of vision. Most of the things which present as a sudden thing usually have a disease which is quite profound. Now this can be only the visual acuity loss, or it can be the loss of the part of the visual field. Whether it is painless or painful, red eye, whether it is associated with photophobia or lacrimation, and mind it, sometimes a very urgent debilitating ocular disease may not be having any external sign, as we saw in the morning CRAO. So red flags in the red eye, I'll just highlight 4 points, because already we have discussed red eye, but you must be aware of that a red eye which is presenting with the pain, decreased vision, having an altered pupillary reaction. So pupil is a very important part of the eye examination. If your pupil is not normal size, normal reacting, your patient is having something serious, it is not a normal red eye. Loss of corneal clarity or ulceration. So these are the signs, these are the red flags in red eye. These are the type of the patients which need an urgent ophthalmology referral and management. So the red eye can be associated with infections. We have already discussed about keratitis and perforated cornea ulcer. Two more conditions which require a mention is endophthalmitis and orbital cellulitis. So endophthalmitis patient can present to you as an acute onset of pain and visual loss following a surgery, an ocular surgery. So this can be post-operative following surgery, it can be post-traumatic, and sometimes it can be endogenous. Endogenous means that they can present to you with lot of conjunctival chemosis, the red eye and discharge. You will see the cornea is not very clear, it is hazy. There is a fibrinous exudate in the interior chamber which is suggestive of very intense inflammation. There will be a hypopyon, again suggestive of intense inflammation, and in the vitreous chamber there will be vitritis. Because of that you will not be able to see the red reflex. Now such kind of patients, they require urgent ophthalmology referral, so in which we treat them, sorry, it's a mistype over here, we have to treat them with intravitreal antibiotics following a vitreous tap which is sent for the culture, and if the condition is very severe and does not respond to the antibiotics, we have to do the vitrectomy. So these patients, you may save the eye of a post-operative patient if you timely diagnose, pick up these kind of conditions and send the patient to an ophthalmologist. Then orbital cellulitis, again it's a life-threatening infection which involves the soft tissues behind the orbital septum. The patient will have a rapid onset of severe malaise, fever, pain, and having visual impairment in the form of visual loss. It presents with usually a unilateral red orbital swelling. You can see here, the lids will be markedly swollen and the area around the eyeball will be swollen. There will be marked conjunctival chemosis. The eye will be painful and warm to touch. The movement of the eyeball will be restricted. the pupillary involvement can be there, and if you look with your ophthalmoscope, you might find certain optic nerve swelling or the congestion, optic nerve hyperemia. So these patients, they require again urgent identification of the problem. It is not something just a conjunctivitis or eye flu. We must know how to differentiate it from the normal conditions. So such patients, they require inpatient admission and intravenous antibiotics, blood counts, culture, CT orbit, sinus and brain are required to look for the cause, and ENT assessment. So these were the two important conditions I wanted to give a brief about. Another acute condition which a person can present to us as an emergency, because emergency we must understand which patient feels an emergency also. So if a patient is having a very painful red eye, he will come running to you and ask what needs to be done for this. So here the intraocular pressure goes very high acutely due to secondary blockage of the aqueous humor outflow. This kind of condition, which is due to the pupillary block, can happen in predisposed individuals having small eye, shallow interior chamber, in the conditions like dim light as in theaters, in prone position, and with certain medications like anticholinergics, sympathomimetics, etc. So here again the eye will be very painful, red eye, having photophobia, headache. Patient may have nausea, vomiting due to very high intraocular pressure and decreased vision. So these symptoms of headache, nausea, vomiting are similar to which we see in raised ICT. So acute angle closure glaucoma patient, one might confuse it with having a raised ICT and send the patient to neuro, where actually a patient needs an ophthalmology referral. So how we can judge that? A very simple thing, digital assessment of the IOP. So if we digitally touch the eyeball and try to assess the pressure, it will be very hard globe-on palpation. Redness is there, pupillary reactions, again the importance of pupil, it will be semi-dilated pupil not reacting to eye and a hazy cornea. So I think one can very well make a diagnosis of acute angle closure glaucoma in such a presentation and do a required urgent referral, because we need to control the pressure acutely with the use of intravenous mannitol, acetazolamide or syrup glycerol in non-diabetics, topical treatment in the form of intensive pilocarpine eye drops and beta blockers. Once the pressure is controlled, cornea becomes clear, we do a YAG laser iridotomy so that patient does not suffer from the similar attacks again and again in the similar conditions, and the prophylactic treatment of the fellow eye, because usually the shallow ACs are bilateral. Acute interior uveitis again presents with red eye. Again the features are, all those red flags are there: red eye, photophobia, decreased vision, sluggish pupil, circumcorneal congestion. But here if we do the slit lamp examination, we will see the cells and flares and a hypopyon. This type of conditions, they also develop very acutely and are very discomforting to the patient. Why I have put it in the emergencies? Because here where you need urgent and appropriate treatment with the topical steroids. In eye flu, you have been advised that you should not be giving steroids to every red eye. But here, if we do delayed treatment, if we do improper, inadequate treatment, then the long-term complications of the uveitis can happen. The patient might have recurrences, or he may be having chronic uveitis. So one has to learn to identify the certain eye conditions which require the treatment at the appropriate time. Now we'll come to certain vascular conditions, again partly have been touched. So CRO is again one sudden event which is an ophthalmic equivalent of stroke. The importance of CRO is that the presentation is sudden and profound. So here you will not see any sign in the interior segment. So there will be no external signs, but if we look at the fundus, so we can very well see an area of retinal opacification along with the cherry red spot, which is the preserved foveal vascularity. So if we look into the eye with the ophthalmoscope, one can easily identify such a profound presentation. So we can confirm the diagnosis on angiogram. The treatment urgency, as was discussed in the morning by Dr. Ritesh Nerula, it is urgent and emergency because the retina will suffer from irreversible ischemic damage after 6 hours. So if a patient comes and we have made a diagnosis of CRO, and if we take up that patient for treatment within 6 hours, there is still a possibility of recovering vision. Though despite treatment, most of the time the prognosis is very poor. So treatments modalities are directed towards lowering IOP, dislodging the embolus, and the direct vitrectomy, where we are directly massaging the central retinal artery to dislodge. So in the lucky cases who reach in time, you might be able to salvage the eye, but the more important thing is to look for systemic factors in a patient who presents to you with CRAO, so that the end organ damage does not happen in heart or in brain and he actually gets a stroke. So such kind of patients need to be systemically treated. So CRVO, again, it is not as bad as CRAO, but a person can be going to his bed happy, having a good vision, and he might get up in the morning with loss of vision in one eye. So it can be again as sudden as this. This happens usually in the patients who are uncontrolled hypertensive, diabetics, or in certain younger patients with prothrombotic states. Presents with sudden painless loss of vision. Though you need not send the patient immediately, but if we treat the condition timely, we can save the vision in these eyes, because otherwise the ischemic areas, they can keep on increasing and a person can develop loss of vision secondary to macular edema, ischemia and hemorrhage, and there are many long-term complications. If these kind of patients are missed, they can land up after a few months with optic disc neovascularization and neovascular glaucoma. And with the treatment available with the intravitreal anti-VEGFs, dexamethasone implant, laser, vitrectomy, we can salvage these eyes and give them useful vision and prevent the complications. Another vascular event which can affect the eye is the arteritic anterior ischemic optic neuropathy. So arteritic means that it is related to a systemic vasculitis, most commonly polymyalgia rheumatica or giant cell arteritis. Here, patient again suffers with a sudden profound unilateral loss of vision, which usually is accompanied by periocular discomfort. So such kind of presentation you should keep in mind if you are having an elderly patient with history of headache of recent onset, mostly a female, who gives the history of scalp tenderness and jaw claudication. On examination, you will find an RAPD. If you look at the disc, you will find a pale disc edema. The importance of this condition is the eye which has been hit by AION, you will not be able to salvage it. It is gone. But very rapidly, sometimes the other eye involvement can occur within 24 to 48 hours if you do not start these patients on high dose systemic steroids. So here, do not waste time in getting the investigations done, biopsies, blood workup. Here the first line is to start the systemic steroids and then work up the patient. So another condition I would like to touch upon is the retinal detachment. So retinal detachment happens mainly because of two reasons. One is labeled as rhegmatogenous, in which there is a pre-existing retinal hole or a development of retinal hole or tear due to trauma, or the non-rhegmatogenous, which we see in advanced diabetic retinopathy or in inflammatory conditions. So what are the risk factors? So trauma, occupational trauma can sometimes lead to retinal detachment. Sometimes the development of detachment may be delayed. The person suffered trauma 1 month prior, he is not having any problem, he developed a retinal hole which was undiagnosed, and now he is presenting with the retinal detachment. Blunt or penetrating injuries have high risk, high myopic patients, and in elderly age group secondary to acute PVT. So here the central vision will be reduced if macula is detached. Sometimes the patient may have good central vision, but they might complain a curtain-like field defect in their vision. There may be history of floaters and flashes of light. Mostly there are no external signs. So patient may not be sometimes even aware of that he is having or developing progressive retinal detachment. So here this fundus diagram shows you that the central retina is well attached, but there is a superior retinal detachment. Such kind of detachment, they can progress over hours and they can involve the macula. And here there is the detachment which is already involving the macula. So treatment is surgical in the form of scleral buckling, pneumoretinopexy, or vitrectomy with internal tamponade, depending upon the type and extent of retinal detachment. The important is to know that urgent ophthalmology referral, especially in macula on RDs. Macula on RDs means where the central macula is attached, requires urgent surgery to maintain central vision. And in the case of macula off RDs, still the early surgery gives better prognosis than a late surgery, and it prevents the proliferative complications. So the thing I want to highlight is we should be aware of these conditions. We should be able to diagnose the conditions which are potentially threatening to the patient's vision, and after the appropriate diagnosis and examination, they should be receiving a prompt ophthalmology referral, because everybody would agree with me that safe vision is equivalent to saving life. Thank you for your kind attention.